Good afternoon, I'm Dr. Tycel Phillips from City of Hope National Medical Center in Duarte, California. And I'm being joined at this wonderful EHA meeting in Madrid, Spain by Dr. Manali Kamdar, an MCL expert from the University of Colorado. And today we'll be having a conversation about the role of BTK inhibitors in mantle cell lymphoma. And so I'll start with Dr. Kamdar. What do you see as far as the role of BTK inhibitors in MCL today?
I think with all the clinical trials that eventually led to several BTK inhibitors approved for patients with relapsed mantle cell lymphoma, I think it certainly changed the outcomes of patients with relapsed mantle cell. Previously had a very dismal outcome, but because of targeted inhibitors like BTK inhibitors, covalent as well as non-covalent, I think the outcomes have certainly improved. And of course, the first splash was made by the advent of ibrutinib with the overall response rate in the 60s, CR rate in the 21%. Of course, this was in the pre-PET era. This was, of course, with patients who were heavily pretreated with chemotherapy. And then there was the advent of the second generation BTK inhibitors, acalabrutinib, zanubrutinib, looking much better with the CR of about 40–45%. I do believe that these drugs add tremendous value to our patients with relapsed mantle cell lymphoma. At this point in time, it's really important to figure out where they are placed in the armamentarium of our toolbox, because if they work in the third line setting, in the second line setting, clearly anything works in the next line of setting, you'd want to bring it forward. So there are certain trials that are being investigated in the frontline setting. So I wanted to ask you a question with regards to BTK inhibition. Could you throw more light on the non-covalent BTK inhibition, covalent BTK inhibitors? Where do you see them in the relapse setting, and how do you see them moving forward in the frontline setting?
Yeah, very good question. Obviously, in the US, we know in the covalent BTK inhibitor setting, we've lost ibrutinib after the SHINE trial. So at this point, we have two covalent BTK inhibitors. We're all anxiously awaiting to hear the presentation from Dr. Michael Wang of ECHO to see where acalabrutinib falls into that situation. I think we're all having bated breath to hope we don't necessarily have a repeat of SHINE in that situation. At which point we'll really be left with zanubrutinib as a second-line drug. But I think looking at the covalent drugs overall, zanubrutinib and acalabrutinib, at least in the US, there's really no particular difference between the two. I think it's just investigative preference, given the safety profile and efficacy seems to be very similar between the two drugs. So moving forward, obviously, we may just be dictated by accessibility, which is something out of our control. Now, the new kid on the block being pirtobrutinib, which is a non-covalent BTK inhibitor. There is another non-covalent BTK inhibitor being studied, nimtabrutinib, but pirtobrutinib has an approval right now in the post-BTK space. Obviously, the big claim to fame in that drug is that in addition to having some efficacy in a post-BTK setting, again, with about a 50% overall response rate post-covalent BTK inhibitor, 25% complete response rate, I think the tolerability of this drug was very impressive in this patient population and supports, I think, some of the emphasis, as we know, with Bruin 302, potentially allowing this drug to move into the second line, which, obviously puts a big emphasis on what we will do with covalent drugs if a non-covalent goes first, because we don't really have any data about the inverse of how these drugs work.
I think, genomic profiling and tumor profiling would be of utmost importance. I think we have seen a little more data in CLL with regards to the C481S mutations, the 278 that develop with PERTO. I don't think we have that much granularity in mantle cell lymphoma, because that, I think, would be super helpful. But with that, I also wanted to ask you a question of the high-risk mantles, right? So TP53 mutation, especially patients who are enriched for those, patients with complex karyotype, blastoid, pleomorphic. Where do you see TP53 mutation play a role in the determination of treatments?
Yeah, I think overall we probably need to start at the beginning, which will lead to a bigger conversation in the front line, because I think that's where the problem normally starts. Historically, we both know that chemotherapy seems to perform very poorly in this patient population. then adding drugs to that frontline setting seems to make a difference. I think the Triangle trial showed a substantial benefit when you add ibrutinib to chemoimmunotherapy versus just chemoimmunotherapy alone. And so I guess moving forward, the questions will be, do we need chemo at all in these patients? Do we just start with targeted agents and sort of extrapolate that along? I think the Bovin trial that came from MSK supports just a chemo-free approach. And smaller numbers, again, very impressive PFS very early though. And I think as we move along, we'll start seeing more and more of these trials mature. But I think that flips to the other question. I mean, I guess as we see these BTK inhibitors move earlier and earlier, obviously, if they do become more established in the front line, then I guess what does that sort of mean for us in this second line and beyond?
I think in terms of like the relapsed mantle cell lymphoma toolbox that we have the BTK inhibitors, we have BCL2 inhibitors, we of course have CD19 CAR T cell therapy, we have bispecific T cell engagers. You have led this study with glofitamab with CD20 BiTEs. So I do believe that all of these agents, which are basically chemo-free, are going to have to be used if BTK fails after frontline. So I do believe that the outcomes for patients with mantle cell lymphoma continues to look quite promising in this day and age.
Yeah, I think we're all excited to see where it goes. I think the next couple years, like I said, as we get more readout from these trials, some big questions, obviously, Bovin's durability, and then with Triangle, I think the million-dollar question we all have is, how will these patients respond to retreatment with the BTK inhibitors after the 2 years of maintenance? Will we still get that same longevity that we sort of see in CR patients in the second line? So very exciting times, very exciting drugs, and I think...
Looking forward to making more important and significant milestones happen in mantle cell lymphoma.